Good morning. This is Erin with the Department of Medicaid. It's not quite 10 o'clock and we're still clearing the waiting room, so we'll give it just a moment before we get started. So far, Wayne, I see you, Johnny, and Brad. If I missed any other TAC members logging in, just let me know.
Aaron, this is Doug. I'm here.
Sorry about that, Doug.
No worries.
Sometimes you guys come in big groups and I miss you coming in.
Aaron, do we have the waiting room about cleared down?
It is just now clearing. I just entered the last person.
Okay,
I now have you, Johnny, Doug, Ann, and Brad on. So that gives you a quorum.
okay, great. All right, as the chair, I officially call the meeting to order. Aaron has established that we have a quorum. Does anybody want to make an approval for the minutes or a motion for the approval of the minutes from the last meeting?
So move.
Doug makes the motion. Does anybody second that?
I'll second.
Brad seconds it. Is there any discussion on the minutes? Does anybody have anything to say about those? All right, committee members only, all in favor, say aye. Aye.
Aye.
Aye.
Any opposed? Okay, the minutes are approved from the last meeting. Old business, we start right in on the general children's waiver update. Aaron, is who from the cabinet is speaking today in regards to those topics?
Hey Wayne, it's Alicia. I will be presenting on behalf of the department today. Before we get into old business, if I could just take a moment to share with the group here that we now have a new director for the long-term services and supports. So we're excited to announce that Carmen Hancock, some of you all may know her from previous work at Communicare. But she is currently in a meeting right now, so she is not available to introduce herself. If she gets done with that meeting, she's going to try to join. And then I'll let her kind of give her background to the group. But just wanted to share the new exciting information that we have on that. And then I will jump right into the old business here. As far as the general children's waiver updates, I think this kind of goes along with the new business, the Families First initiative. So I'll just kind of cover both of those here at the same time. We did have a town hall last week and we had well over 200 people that were there. So super excited to see the involvement. What is next is between April and June, there should be some additional roundtable discussions. And then the tentative goal is to submit this by the end of the year, so 12/31/2025. And I do have uh, just a quick like 6, 7 slides in a PowerPoint that I'm going to share with Aaron. And this is kind of what was shared in the Families First town hall, just to give you all some additional information if you all were not there able to attend. But it is, you know, a comprehensive multi-year initiative aimed at enhancing the existing system of care for all the Kentucky children and youth throughout the Commonwealth. So Aaron, I'll send that out to you so that you can share that with this group as well.
Thank you.
And I don't know if you've got any questions. Oh, I see Amy. I would say, I don't know if I'll be able to answer them because there's lots more information to come. And like I said, this is a huge effort cabinet wide. So, but Amy, if you want to ask or make your comment, and I will see what I can do to assist.
You thought you were going to get away without me asking any questions.
I know, right? Go ahead.
So I realized that this is number one, congratulations. I know that this was a lot to put together, and I was at the town hall and I thought it was great. Specifically, about a children's waiver, because it was referenced several times in the presentation at the town hall as being one of the things that is intended to be completed as part of a holistic system of care for Kentucky's children. When you said submitted by the end of the year, did you mean specifically a children's waiver or the whole program for approval?
So my understanding is it's going to kind of be the children's waiver because, again, this is a multi-year thing. But and I don't have there was a roadmap. You probably remember Secretary Freelander showing that, but that is my understanding. Again, you know, all this is subject to change, right? As we get more involved, get those discussions. But that is my understanding at this point.
Perfect.
Again,
thank you.
Things could always change. So
no, that offers a little bit more clarity. And so there will be, and again, Secretary Freelander said this at the event last week, that there will be roundtables for various topics related to all of this. And you all will be communicating like signups for that kind of stuff, or?
yeah, I know we sent out, like, just even for the town hall, we sent it out through all of our listservs and everything. So just continue to watch through the communication. I know they put it on social media. And like I said, emails go out to everybody. So continue to look for that type of communication coming out.
Thank you. Appreciate it.
You're welcome.
Wayne, this is Melanie. Can I ask a question?
Sure, go ahead.
Okay. Thanks, Alicia. I appreciate when you sent out the information, I circulated it on every group that I'm involved in. So thank you for that. I did want to ask one to celebrate autism is April 1st is Autism Awareness and Acceptance Month. So happy April, everyone. But as far as the children's waiver, I've been a part of the team that was initially working on that. Will that group still continue to meet with the development of the waiver?
So, you know, if you remember way back, I'm going to say a couple years ago, maybe there was we went throughout the state or whatever, and they have that information, but this is really even grown into such a larger collaboration.
Yeah.
But all that information has been captured and was shared.
Okay. And that there were several different diagnoses, you know, as well as mental health issues and concerns. Is that still the framework moving forward with this?
You know, I don't want to speak on the exact framework because again, looking at, like I said, it's really just morphed into a larger project per se, right? But getting those services needed to our youth and, you know, throughout the Commonwealth. But I think as we have those discussions and roundtables, that's going to, you know, bring to light some additional things. And so definitely, and thank you for sharing it on all your social media platforms. We really appreciate that. So the more people involved, the better that, you know, it makes us, right, as a whole to work together to get, to see what services are needed and to get those put in place. But just keep lookout for additional communication. And I would, you know, just advise that you all definitely stay involved as we move forward because we're going to need your help and your partnership.
Okay, of course. Thank you.
You're welcome.
Johnny's got a question. Go ahead, Johnny.
Hey, thanks, Wayne. Alicia, I was just wondering, is this, so this would be a new waiver, and I'm wondering since the passage of 695, is it, I guess, approved by General Assembly or will be approved or subject to approval before going forward, or do you know?
So you're kind of asking two different things, and I
Okay.
just want to make sure that I clarify myself when kind of say children's waiver, right? That
Okay.
doesn't mean that it's a 1915C waiver. It could be an 1115. There are
Okay.
like so many different what we consider waivers that are not like home and community based under the 1915C. So I don't know how that's going to be submitted. That is all subject to, you know, to be determined later, right, as we move forward in determining how this will be. Now, as far as the House Bill 495, you know, I don't want to really speak on any of that at this point in time. I think internally, our executive staff is reviewing that and looking to see what we need to do for the future, what's going to be required, and just and I think additional information, you know, after a few weeks or so, and once we, you know, all get together, that we'll have some more concrete information on that. So I definitely don't want to speak to any of the bills that were recently passed.
Okay, thank you. I don't blame you.
You're welcome.
Okay.
Aaron, do you see anybody else with a hand up or anything? I know you can see more people than I can, so,
I do not. I think we're good.
okay, all right. General updates on Medicaid 2025 initiatives. Alicia, I'm assuming you're doing that update too?
Yeah, I'm on for all of it. I don't
Okay.
really have a whole lot of information here. You know, I do know that obviously the Families First that we just talked about is a huge thing that's going on right now, and you know, really is at the forefront of Secretary Freelander. You know, with our children, but we also have the reentry as well, and then we've got quality assurance stuff that's going on. So I'm not sure if you all have specific questions. I don't think I'm going to be able to answer those today. But if there are individuals, you know, if you have specific questions where we need to get and bring in additional staff from Medicaid who are maybe over those programs, you know, let us know, and I'm sure Aaron can help me get the correct staff here at our next meeting to talk about any specifics that you're interested in.
I see Amy's got her hand up. Go ahead, Amy.
You may not be able to answer this, but in previous TAC meetings, we have heard individuals from Medicaid talk about potentially, obviously, much needed regulatory changes for the 1915C waivers. Because right now, you know, our regs don't align completely. Do you have any time frame of that or no? And it's okay if you say no.
No, I don't have a time frame just yet of that. I know that we actually had a meeting on it earlier this week. Session really took up a lot of everybody's time, and especially our regulatory folks that help us write those regulations. Jonathan Scott, I'm sure many of you are probably familiar with him, but that is something that we are continuing to work on because, you know, in the perfect world, we like everything to be approved on the same day and everything to perfectly match. And unfortunately, that's just not the way that it occurs sometimes. And but we are still working toward that. And then, of course, anytime that they are out there, that we're going to submit anything, you know, there will be the public comment. We will share on all of our platforms, everything like that, to make sure that you all are definitely aware.
Any other questions for Alicia on that particular agenda item? Okay, the next thing up is the rate study implementation report.
Yeah, so I kind of thought that this one might be taken off after our last meeting, just because everything that was budgeted for and all the changes that needed to be completed were complete as of January the 1st. You know, I do know that you all have mentioned in the past about, you know, needing or wanting the 100% of the benchmark and some different things, whereas I know that Leslie had explained that there were several services that should have been decreased, but the secretary allowed for providers to keep that additional money. And so not everything was at that 70%. Some things are a lot higher. But what I would say is, you know, any additional appropriations would come from the legislators, you know, as we move forward.
Okay, so the cabinet has no plans to go to the 100% of the rate study.
As of right
Is
now,
that what you're saying?
I'm not saying that. What I'm saying is what was budgeted and through the legislators, that everything that, you know, we have completed all of those tasks. Now, when you say 100%, you know, several of the services should have had a decrease. And so they are well over, you know, 100%. So, but right now, we have made all the changes based on the, you know, guidance that we were given and based on the legislators' appropriations for the department.
Okay, the reason that was left as an agenda item is there was a formal recommendation that left the committee last time, Alicia. I don't know if you were aware of it. You know, that the IDD TAC recommends and requests that the Cabinet for Health and Family Services provide a written guideline that outlines the implementation of the completed rate study to 100% implementation, to include specific timeframes and implementation dates. That's the reason it was left on the agenda as old business, because that was a formal recommendation that left this committee
And y'all
and
took
went to
that
the
to the
MAC.
MAC, so
Yes,
it's now
it's
at
been
the MAC
reported to the
level?
MAC.
Okay, yes, at the MAC level. Okay, I'll just make
Oh.
a note of that.
Alicia,
Yes, ma'am.
that recommendation was sent out to leadership right after the MAC. I can forward it to you.
Okay, yep, that will be great. I will follow up with Leslie or Dr. Hoffman and Carmen on that.
Amy, you got a question?
Well, I just wanted to add a clarification piece. It is my understanding that while the TAC, and again, I don't want to speak on behalf of the TAC, but I think everyone understands that some rates were at the time of implementation higher than the 100%. I think what everyone is concerned about is getting those rates that are still at 70%, 80%, 90% up to 100%. I don't know that the TAC is advocating that rates be lowered, but they are asking for an implementation plan to get rates that are underneath the benchmark rate up to the benchmark rate. Wayne, please correct me if I'm wrong.
No, you're correct. Any other questions in regards to that agenda item? Aaron, do you see any other hands?
I do not.
Okay, thank you. The next item is update regarding the 1915C waiver wait list.
So I can provide you, let's see, this would be numbers as of yesterday, so 3:31 early in the morning. And as we say all the time, that these are fluid, right? Some come off, some are added. But as of yesterday, for our home and community based program, we have 3,583 on the waiting list. Michelle P. Waiver has 9,381. And then SCL, their waiting list is 3,589. But just to note, the unduplicated members is 14,538. And as you all know, our waiver year is getting ready to hit a new year in May. And our BHDID team, I saw Blair and I think Elizabeth Markle on here. We will be releasing some additional slots. We do have those slots that also will become available after July 1st. We don't have our plan. We feel like it's finalized, right? But we just need to get approval. But just to kind of give you a little bit of heads up, because we understand that that is a concern of providers and we don't want to bottleneck anybody. We are going to the new additional slots beginning in July. We plan to phase those in over 6 months. So, there's 500. Last time we had 250 slots and we did it over 3 months because we have, the additional 250, which is 500. We plan to do that over 6 months. We do just have to continue to get additional approval and make sure that our executive staff do not have any issues with that. But just kind of a note out there. And then at our next TAC, we can definitely follow up on that as well.
Any questions regarding the waiting list information?
Wayne, this is Melanie.
Sure.
Can I ask another question? There was an amendment that the cabinet did December the 23rd that had the revised or updated rates. Is that in existence at this point in time? It was for the SCL rates.
So I think what you're asking is, did all the rates in the previous amendment that was approved by CMS, did they all go into effect as of
Yes.
January the 1st? Yes, everything went into effect January the 1st, and all of our systems were updated to allow for, increased billing.
Okay. Thank you.
You're
Sorry
welcome.
to ask a question.
No, you're fine.
Well,
Absolutely. Do you want
Any
me-
other questions? Oh, Johnny, go ahead,
Johnny's
Johnny.
got his, yeah, I see Johnny's hand.
Hi, thanks, Wayne. Alicia, do you know if there are any people who received waiver funding from the previous round that have not yet been able to access services due to, provider access issues or whatever reason? But are there folks who, for whatever reason, just cannot or haven't been able to begin waiver services?
I understand what you're asking. I think that would be I'm not saying we couldn't figure it out, but it would be a little harder because we we were also allocating additional slots in there as well, because during that time, because we're always reconciling slots, right? If people don't access services, maybe they moved out of state, maybe they're in a different waiver, they decide that, maybe they're in SCL and they got a Michelle P. waiver slot. We try to catch those up front, but, majority of people don't want to go from SCL to Michelle P. waiver, right? So But we constantly are reconciling those. I feel like it might be a little difficult to pinpoint that. I'm not saying, like I said, I'm not saying we couldn't do it, but it would be just maybe a little harder. So I don't really have an answer for you on that because those slots, so you don't have slots that are earmarked that says these are 2025 slots or whatever. They are, in our system, you have like the total number, what 10,800 or whatever it may be. You just got that total number in there.
Okay. Yeah. Okay. Thanks. Appreciate it.
You're welcome.
Any other questions for Alicia on that particular issue?
You want me to go ahead and go to the medical marijuana?
Yes,
Okay.
that's the
yeah.
next item.
Yeah, I mean, I can run down through these if people don't have questions.
I have a question.
Oh, okay, Myra.
I'm not for sure if this is the right category. Is there any update on an FMA statewide? Because that is one of the holdup that we're having is, we've only found one FMA agency that will work with HCB2, and getting that process going took several months. So is there any kind of an update on if we're going to try to get an FMA statewide for PDS?
So as you know, with RFPs and stuff, that's not something that we could talk about publicly. Because if we was to talk about stuff like that, there's all kinds of police right out there. Not the police, but internal
Okay.
police that could really derail anything going on or anything like that. So I don't really want to speak, but we definitely, Myra, hear you on the issues of the finding FMS providers. I actually have April beside me because she's going to, I think, be given an update here soon for me. But
Okay.
she is taking notes, and as a state agency, we hear you, and we are working to
Okay,
try to
thank you.
address those concerns.
Yeah, that's the panic we get when people get the letters and I tell them how long it's going to take the process. They're afraid their letter, the 60-day window is going to run out.
Right.
Yeah.
And we also are looking at those individual cases, right? Is there anything you wanted to say?
So
April is going to jump in and speak. I don't know if she'll be on camera just because, oh, there she is.
So on those, we ensure that we have those identified and that they will not be penalized for waiting for PDS. So we should have all those individuals identified with a banner message in MWMA. So we do not want to penalize anybody waiting for the option of participant direct services.
Okay.
And if we need to help also in trying to get them traditional services or whatever in the meantime, because, if somebody definitely needs to be on the waiver and needs services, we don't want them going without. Definitely will work with you all with the operating agencies to try to get them traditional services in the meantime.
Okay. Thank you so much.
Thanks.
You're welcome. All right. I think we're moving on to what medical marijuana. So we have met with our legal team, our general counsel on this, and we actually have another meeting coming up this week to meet with him. I do understand that, we are getting questions about staff, about participants wanting to use marijuana. What I can tell you as of today, okay, again, we are meeting with legal again, but it is illegally, federally. And so that doesn't change any of our regulations or anything like that. But as we get additional information from general counsel and everything, we can share that.
Questions about that?
Hey, Wayne, we would just ask that whenever the cabinet does decide upon a direction, and if that direction is it's federally illegal, follow the regs, or if that direction is something else, that they do issue an official provider letter, just so providers have something in writing that protects their position in case, you know, an issue arises, whether that be with a participant and, you know, his or her physician or an employee. So whatever the final answer is, and, you know, the answer is the answer, we just would love that answer in writing.
Understood. Thank you.
Anybody else have any other questions about the medical marijuana guidance? Do you see any hands, Aaron?
I do not. I thought I heard someone, but it could have just been someone not muted or
Aaron,
someone in the
no,
background.
I'm sorry. I think there's staff up here going through maybe maintenance staff. I'm not sure. They're right outside
Oh,
of
okay.
my door, so I apologize to you all. And I don't have usually I try to have my headphones on, which helps a little bit, but with April in my office, yeah, we're working in cubicle world, so I apologize.
No worries. I just want to make sure I didn't miss someone.
Wayne, do you want to go ahead and go to the new business?
Sure, absolutely. Let's go ahead and cover
Okay.
the PDS services agenda item there, and then the legislative. Well, yes, we can go ahead and do the legislative one that Melanie asked for also.
Okay. So you want to do the PDS right now?
Yeah, because you've already covered family first initiative.
Yeah, I was
right?
gonna say, yep, I've already covered families first, so I think the only thing left for the cabinet would be the PDS services here. I'm just taking a quick look. And April is actually going to be covering that for me, so I'm gonna slide it over to her.
Hi, yes, so we are keeping track of the PDS interests. Again, I know Myra was in particular asking some questions about that. That allows us to put that banner on MWMA to ensure that that participant is not penalized while waiting for the participant direct services. And then again, if you all need assistance with locating a traditional providers, we're also here to do that, DMS as well as our operating agencies. So we do have, we are keeping up with those individuals. And again, once we receive that PDS interest form, we are updating MWMA as well as, that information is coming from our providers. And again, that information, of course, is based off of the information that is self-reported by the agencies. So we are tracking those, and we do have a list of those. And Aaron, I believe Amy may have her hand raised.
She does,
Go
yes,
ahead,
ma'am.
Two things. One is just a comment and the other is a question. The question is, are you all seeing any improvement in, because you've implemented some changes over the past year to try to address, the issue with PDS. Have you seen any improvement? And two, anecdotally, I am hearing and seeing from a lot of traditional providers that when families inquire about services, and I think this may be specifically a tough issue with HCB, obviously that's where I'm hearing it the most, but it doesn't mean it's not affecting all waivers, is that when families are inquiring for services via a traditional route, the agency is saying, we don't have staff. Do you have anyone in mind that we can hire to do this? And so the problem essentially becomes the same. You can't find PDS staff or you can't get PDS. And then the traditional agency also doesn't have staff and is also asking for staff recommendations of someone to hire to provide the care. So I didn't know if you all were hearing that at all, but I did just want to make that note.
I have not heard that note in particular, and I looked over at Alicia. I mean, we usually keep each other informed as well as the sister agencies. If there's, questions about traditional staff, I had not heard that at all, but we will make note of that, and we could do some follow-up on that.
And just, have you all seen any, on your end, seen any improvement with the PDS? Wait.
Yes, we have. We have seen some improvement, and also where our sister agency, Department for Aging Independent Living, has been able to certify some of the traditional agencies for PDS case management. We're terming that expanded PDS case management. We have seen some of those numbers. They have decreased some since we've been able to offer certification to those traditional agencies. Again, I know there is some limited bandwidth with some of those FMAs, working with those PDS case managers. And again, along with Medicaid and Dale, we continue to work to support those FMAs. I know that Dale has continued to have meetings to ensure that, we're covering as many as we can, as quickly as we can, based off of, staffing ratios to be able to do that.
Any other question on the PDF stuff? Do you want to go ahead and cover the legislation requiring prior authorization, any impact on services? Melanie was the one that presented that. Melanie, did you want to go into anything further on that,
Well, yes, and
agenda
I
item a
think
little bit deeper?
it's involving legislation that you commented on earlier. One, I did want to respond to the item that was just before about PDS services. I had the honor of serving on the PDS work group, and I know that there's great effort being put to try to improve, and so I'm hopeful. And was a great question by Amy Stayed about just what's going on with PDS in my world with connecting with caregivers, families, and self-advocates. That's definitely been an ongoing part of the conversation. So I'm thankful that they're increasing opportunities for people to receive services. The reason I asked this question to Wayne about prior authorization, I read the legislation that I want to say it's 695, whatever the legislation was that created the Medicaid advisory panel that would be all the legislators, and I didn't know if that would influence the ability for prior authorization, or if there would be any kind of impact to that as a result of having the Medicaid advisory. Does that make sense?
Yeah, we're
Okay.
still looking at those internally, so I don't really have any information to share today on the bills that were passed, but we are definitely, executive staff is reviewing that information.
Reviewing that, okay. Because I know on the very last day of the legislature, there was the mental health group came on and was seeking approval to the standing committees for the Senate and House regarding an initiative that they were trying to do to get the needs met for that population. So I'm like, oh my gosh, it's starting now. So it's wonderful that you all are looking at the impacts to prior authorization, because I bet that will definitely influence services.
And if
Any other questions on that?
If
Go
I
ahead,
could
Amy.
add some context that will be helpful for Melanie. If you're speaking about the prior authorization, that was requirements for mental health that were in House Bill 695 specifically, those prior authorization requirements do not affect waiver services. They affect particularly state plan and MCO services that aren't authorized through waivers. And they were specifically aimed at addiction services, addiction and recovery services, if that gives you a little peace of mind. Obviously, I don't have a crystal ball and I can't guarantee what's going to happen, but that was the specific intent of the legislation.
Yeah. But there are also, just to kind of add on to what you said, Amy, there are people that would substance abuse and have developmental and intellectual disabilities, so they might cross paths down the road. So I'm like, oh gosh, it's getting very involved as time goes on. But just in terms of the prior authorization, as you are looking, will there be a work group in your leadership, Alicia, to kind of look at those issues, and will people that access services through the waivers be included in that in those conversations?
That's not something that I can answer today, but what I can
Okay.
tell you is for our waivers, all of our services are prior authorized already. They have, because the MWMA system, the Medicaid Waiver Management Application System, that's where case managers put in all of those services. And so they are already being prior authorized today.
Okay, but help me to, and I might just be totally misunderstanding, just with my humble viewing of what happened with the legislature. I thought that this might be an additional
Melanie,
Yeah.
the bill reinstates prior authorization requirements that were in place prior to 2020, prior to COVID. So it does not create new prior authorization requirements. It just puts the ones that were in place prior to COVID back. And again, they don't have any effect on waiver services, because waiver services are inherently prior authorized, whether that be through CareWise, actual Medicaid employees or the case manager. There are various ways in which those get prior authorized. But no, the bill reinstates requirements that were already in place prior to 2020, were removed, and now they're back in place, if that makes sense.
Okay. Thank you for that clarification.
Any other questions on that particular issue? Okay, we're going to move back up to the top underneath the new business, and we're going to have a presentation and discussion of family councils. That's going to be done by Marla Carter. Is Marla on, please?
She is, and she should be a co-host. You should be able to share your screen.
Okay, give me just a second then.
Welcome, Marla. Appreciate you coming on our call here and
Thank
presenting
you.
some information on this.
Thanks. All right, can you see my screen?
Yes.
Okay, because I can't see
we
you
see
guys
you.
anymore. Oh, you see me. Oh dear. Okay. All right. Do you see, Aaron, can you see me moving around?
I can see you. We can't see your screen.
Well, let me just talk for a minute. How about that? So my name is Marla Carter, and so I'm excited to be here today. I've got a little bit of a different background than you guys, but all of us are working with vulnerable populations. So though my background before all this is in education, elementary education, family circumstances have led to my serving and advocating for those who live in long-term care. Can you guys still hear me?
Yeah.
We can, and
I lost you.
I'm screen sharing your presentation, Marla. So when you're just let me know to change pages as needed.
That will work. Great. Thank you. I apologize. I am on a new device, and also I'm done hundreds of Zoom meetings, but I've not been the official presenter where I'm sharing a screen. So give me a little grace, please, if you don't mind. I have served on the Green River Area Development District Ombudsman Advisory Council as a consumer member since 2019. I was part of the family council in the skilled nursing facility where my mother-in-law lives. For a while, I was the president. Additionally, since 2020, I have been part of the National Caregivers for Compromise group. I've worked with lawmakers at the state and national level to draft legislation that will uphold the right of nursing home residents to have in-person visits with loved ones, even during times of where regular visitation has to be restricted. I actively participate in training and info meetings with the Consumer Voice, Moving Forward, Great Panthers, My advocacy work is definitely not something I ever thought I'd be doing, but it's definitely a calling. And I volunteer weekly at the nursing home to lead a church service and visit with the residents. And so I have personal experience with personal care homes, skilled nursing facilities, and the guardianship system. All that to say, that was a long way of saying I'm, quote, in the trenches and have been for several years. So, and I will start by saying I realize that the laws that regulate skilled nursing facilities are not the same as those that regulate SDL homes or intermediate care facilities, assisted living. But in the case of resident and family councils, I firmly believe there is no question that all parties, providers, residents, families can benefit. Because no matter where we live, we all want to have a voice. And when we work together, we do better. So now, Erin, let's see if we can go back to sharing my screen. Yes. Hey. Wondering if it will let me.
Marla, I'm screen
Yes.
sharing. Do you need me to go back a slide?
Nah, you can leave it there. That's fine. You have my note. Well, you can follow along. It goes along with what I'm saying pretty well, I think. I hope I did a good job anyway. So I wanted to start, this may be a weird place to start. I wanted to start with what family councils are not. They are not support groups. That's a biggie. They are not gripe sessions for families at all. They are not part of management of a facility or a care home, nor do they have any authority to be able to tell providers what they have to do. They're not run by anybody other than family members. And again, have to reiterate, they are not, gripe sessions, bash the management, that kind of thing. Not at all. So what are family councils? So that would be the next screen. So this is the official definition. I'm going to give you the official definition, and then I'm going to tell you about their structure and then share a little bit of my personal experience. So the purpose of a family council, if you're not familiar with them, is to improve the overall well-being of residents by giving families a platform to voice concerns, propose solutions, and participate in decisions that affect the care of their loved ones. So next screen. And the right to form a family council in long-term care for Medicaid, Medicare certified facilities is protected, of course, by federal law under the Nursing Home Reform Act of '87. And you can see the first part of that regulation there on the screen. The resident has a right to organize and participate in resident groups in the facility. Now that includes family groups as well. Next screen. I'm not going to read everything word for word, you guys. I'm going to assume you can read that yourself. The staff, visitors, and other guests may attend resident group or family group meetings when invited. That is spelled out in the law too. And the reason I'm showing you the actual law is because I think it helps clarify what I'm going to say next as far as the way things are structured. So next screen. Okay, so how does this work? Let me explain just kind of the basics of how this works. It is a very simple concept. So the facility, typically, they have to allow you to have a space. Now I realize in places that aren't facilities, so in a care home setting, for example, this would be structured a little bit differently, and we can talk about that in a minute, but the facility allows the family council to use their conference room or perhaps their dining room to meet. And usually it's once a month. It can be once a quarter. And then the facility staff does help with notifying families of upcoming meetings. That can be as simple as putting up a flyer on the door or sending an email or text, incorporating that into how they already communicate with families. So it's a pretty simple add-on. It's not, you're not creating a lot of extra work for the staff. And so special guests can come to the meeting at the invitation of the family councils. And so that's really key to understanding how they work, because in nursing homes, it has been my experience that staff wants to show up all the time. And sometimes you have to say, sorry, no, I'll let you know if we need you, kind of thing. And that families need the space to be able to speak freely. Again, not so that it's a bash session, and this is where the structure comes in, but so that they don't feel intimidated or inhibited or whatever by having a staff person sitting there. And I'm going to talk about that a little bit more later too. But I'm going to give you an example. One time we had, in our family council, we had the housekeeping director come in. We were having laundry issues. That's always an issue, right? We were having laundry issues, and we had her come in and explain kind of the process for how she did the laundry for the whole building, because honestly, we didn't know. And it helped to understand when she explained that. And then we had some ideas for things we could do to make it better that she hadn't thought of. And so we were able to exchange these ideas. And we did see an improvement in items being lost. We've done that with food as well. You might say food is also a big food and laundry, in at least in the nursing homes, are the two biggest complaints in my experience. And so the families might say, hey, we're really concerned that there's not another alternative when our loved one doesn't like what's on the menu. What can the alternatives be? And so somebody from dietary could come in and talk to you, and you could share ideas and go through that. But it's very structured. And that's what I want to talk about next, because if it's not structured, it can easily turn into people, you know how that goes. People just sharing their personal stories, griping, complaining, whatever. You get way off track. So family councils are very structured with officers. There's a president, a vice president. You have a secretary who keeps notes. You have meeting agendas. You use Robert's Rules of Order for communication. So people aren't just, throwing out stuff all the time and speaking, off track. And then this is key. And this is where I think would be the bridge or the common ground for you guys would be families really need to have somebody on the provider side that's going to be their liaison, so to speak. And so when families can come together and come up with a list, what we usually did was we would meet and we would say, okay, we've got let's come up with 3 things that are the most concerning to us right now. And we brainstorm, whiteboard, and then let's invite the staff person to come in, and we'll go over, maybe we'll just go over the top thing today. And you'd make a recommendation. It can be in person, it can be in writing. The staff person doesn't have to show up, but they do have to acknowledge and receive your ideas and get back to you with a plan of action. Again, that can happen in person. That could happen in writing. The staff person is probably going to say, I need to work on this. I'll talk to you next month, kind of thing. But that would be where, in the case of care homes, it might be difficult to provide a space. You might not need to provide a space for families. If you've got a provider that has multiple homes, hopefully those families can get together, but then you would need a staff person that would be the liaison with management to be able to take into consideration your ideas. So, and again, I realize that this does not, the federal law and at the state level laws as well, I realize that does not, it's different and you all don't have the same regulations. I get that. But I think this is such an important concept. It's just, to me, it keeps things de-escalated, if that could be a term. I want to say this carefully and interject my personal opinion, but we go to the next screen, please, actually. Okay, so we've kind of talked about all of this, but the benefits of the family council, you might say as a provider, well, it seems like this just benefits the families. But I really think it is mutually beneficial. It gives families a place to constructively channel their frustration and concerns, and it's an alternative to filing a complaint. I mean, I know that providers would like to get on top of things before a family feels like they have to go file a complaint with the state. And so that makes for less work for everyone. And so that to me is one of the biggest benefits, so that they're not filing complaints with the survey agency, or in your all's case, I'm not sure what the oversight person would be. In our case, it would be the ombudsman. It keeps the facility staff from being overwhelmed by a barrage of complaints all at once, and it allows the families and the facility to focus on, identify and focus on common facility-wide or care home-wide concerns, and make improvements that benefit all the residents. Family members can feel free to voice their concerns, which allows for honest feedback and creative ideas. And then providers have that, they can take that away for continuous quality improvement efforts and better outcomes for everybody. So here's where my personal experience comes in. So in my experience, in long-term care and in most of healthcare, and frankly, I think in society today, there is an us versus them mentality. And that attitude seems, like I said, pretty prevalent. Providers seem to view families from a defensive standpoint, and families tend to be suspicious of providers. And I've seen that in numerous facilities that I've been in here locally. And so maybe that's just my experience, but I think that can be across the board. And so that attitude, that distrust of one another, completely hamstrings our ability to achieve our common goal of making sure that people living in long-term care achieve the best possible quality of life and the best possible care. Family councils help to promote the concept of family members as care partners. If you want to go to the next screen. I believe that firmly that when we look for ways we can work together, when we look for common ground, when we listen to one another and try to understand different perspectives and ideas, we create a better environment for those in our care. It's been my experience personally that even the ability to have a family council, because I've had it both ways, where there were facilities that weren't supportive and then facilities that were. It's been my experience that even just the ability to have the family council goes a long way in changing perceptions of care providers. Families feel supported and empowered when they promote that family council meeting. And sometimes they just want to be heard. People just want to be heard, right? All of us just want to be seen and heard. And so sometimes that goes a long way to soften hearts and attitudes towards providers. And then when providers have a chance to work with families and work out issues before they escalate, when a compromise can be reached, trust is definitely bolstered on both sides. So for me, it's a win-win on both sides. Again, it's just keeping the lines of communication open. I know when I have had a complaint about something and I've gone to and we've had a family council meeting about it, and a staff person comes in and says, well, no, this is how we do things and this is why. It helps me understand, right? And helps me say, oh, well, in light of that, maybe we could try this instead. And maybe I have an idea that they hadn't thought about. So again, just to me, it's a no-brainer. It's a win-win because communication prevents assumptions and prevents misunderstandings. And so I think that anytime you can have increased communication between families and providers, it's a win-win for our loved ones. Again, we're a team. I had the administrator that was at my mother-in-law's nursing home during COVID. That was her term, care partners. She called families care partners. And I loved that. And she meant it and she backed it up with action. But, I hadn't had an administrator call families care partners before. And we are, because we're bringing the part of the resident, the patient, that the personal side, the history, the things that the providers may not know. And a lot of times we're their voice when they don't have a voice. And so there's more emotion involved, obviously. But again, that's why communication is so important, to avoid misunderstandings and assumptions. And if you guys have any questions, I'd be happy to answer them. if you want to know how this would work with you guys, again, I'll try to answer that as best I can. You know, again, my experiences in long-term care, but I think that if you as providers, if providers could say, hey, we have a family council at our, you know, in our homes, I think that would be huge. I think that would win people over. And again, just anything we can do to change the persona of us versus them, where we're a team and we're all working together to care for the most vulnerable.
Marla, is there anything in Kentucky law preventing families from establishing family councils themselves?
Preventing them, no. It is definitely I mean, it's definitely encouraged, and unfortunately, I think in the, at least in long-term care, a lot of families don't know about it if they don't have a family council already existing, you know, in their facility. And so it kind of falls on the ombudsman in the skilled nursing world to be able to start those, but there would be nothing preventing it. No.
Do you know how many family councils exist in the state of Kentucky in comparison to how many nursing homes there are? Because I don't have any idea what that number would be.
That's a good question. I can get the answer. I know that there are more resident councils than family councils. Nearly every facility has a resident council. And so the family council, again, is dependent on families leading it. And so there's not always families willing to step up and lead it. And so again, that I know there are fewer of them in the state of Kentucky, but yes, the cabinet does track that. There, it may even be on the Kentucky.gov website somewhere. I think I've seen it before, but they do try to track that. That number changes and fluctuates, obviously, but there is data for that. Yes.
Other questions, committee members? Go
Well,
ahead, Melanie.
Melanie. I don't know where the little hand is. That was a really great presentation, Marla. Since you cited the federal legislation, did you need to seek out a Kentucky legislator to get language to be able to establish?
No, it's very similar. It's very similar. I will say that I'll give you a personal story. I think it's probably not as, I think everybody knows about resident councils, but the language firmly includes, you know, families as well. And there was a time when I had a complaint with a facility, and it was because they were hindering our ability to meet. And when I spoke to the state surveyor didn't know that that was a protected right, and they thought it only applied to residents, and I had to pull out the state one, and I can get you the exact state one if you would like. Again, it's worded pretty much like the federal, and is part of the Residents' Bill of Rights. I don't know if you all have Resident Bill of Rights on your side of things, but it's very state and federal is very similar.
Thank you. Yeah, that would be very. I'd be interested in maybe you sharing that with the IDD TAC, just to kind of, so we all have the same.
A lot of resources. There's a lot of the state ombudsman. Sherry Culp has a lot of good stuff on her website. Each development district has information available because, you know, again, that's the ombudsman directs that. So I'm not sure in your all's case who would be kind of the go-to person if you wanted to start something like that. But there's tons of materials available online to help you, to help families get started. So I can send you all of that.
Amy, I see your hand up. Go ahead.
I lowered my hand, but I forgot to unmute. And again, I just wanted to piggyback off what Wayne said. While the federal requirement for family and resident councils applies strictly, and state requirement strictly to nursing facilities, it does not apply to 1915C waiver services.
Correct.
Nothing in law that prevents families from doing this.
No.
And from, you know, meeting other families in their area. I think my only concern would be there is this principle that exists within federal law as it relates to specifically community-based services for people with intellectual and developmental disabilities. And that idea is that discussions and decisions about the individual, even if they are not their own guardian, cannot be had and made without the individual leading the discussion or participating in the discussion. And so I do wonder if the family council would undermine that federal requirement of the individual leading the discussion about themselves or the services as it relates to themselves. I think that would be my only concern.
Yeah, so the residents themselves can participate. There's nothing that says they can't be there. Sometimes they are. And so in the nursing home, a lot of times there'll be a representative because there'd be so many. If residents came to a family council meeting in a nursing home, there'd be a lot of them. And so a lot of times they have one or two representatives from their resident council that come and attend. So that kind of they're the voice of all of the residents, but there is nothing that prohibits. In fact, they're often encouraged to participate. And maybe I wasn't clear about that. Sorry, but yeah, they're just because they have. I'm guardian for my mother-in-law. I understand, about still including her in conversations when we have care plan meetings and that kind of thing. They have every right to participate and be there.
Other questions for Marla, please? Do you see anybody else's hands up, Aaron?
I do not, and I have a copy of the presentation I will share with the TAC after the meeting.
Good, good. Marla, I want to thank you for coming on and presenting to us. We appreciated the presentation. They're always a good break from all the stuff that we go through on the agenda and everything. So really appreciate you coming and presenting today.
Well, thanks. It's interesting for me too to sit and listen because again, we're all working with vulnerable populations, and even though I'm on the long-term care side, some of these things, some of the concepts and ideas definitely overlap. So it's interesting for me to hear y'all's side of things. I need to learn more about that too.
Absolutely. Well, we really
Thanks.
appreciate you coming on today.
Thanks. Anytime.
The next agenda item is general discussion or announcements, and it's the discussion of any impacts that CHFS is aware of from current legislation or from guidelines from federal authorities. We know that there's a whole lot of stuff that's going on the federal level right now in relation to Medicaid and everything, and we're just looking for an update if there is any on that, Alicia.
I personally don't have anything, it's business as usual right now. And, as we move forward, we will definitely share anything, any information that we get. If we was to have to change, I get there's a lot of uncertainty out there. And I know our executive staff is monitoring that. But I did, Wayne, if it's okay, I know that on your I'm going to call it the recommendations for the MAC or whatever, you had asked for some additional information on the involuntary terminations. And Elizabeth Markle is here today. We've got that information. Would you like for us to go ahead and share that with you?
Yes, actually, I left that off the agenda out of the agenda today, and I don't understand why I forgot that. I should have had it on the agenda. Thank you for bringing us back around to that. Go ahead.
I'll turn
Yes.
it over to Elizabeth.
Good morning, everyone. I'll go ahead and get these numbers shared. Total number of involuntary terminations in the last year is at 48. Total number of involuntary terminations in the last year, residential services only, are 32. Of the total involuntary terminations in the last 6 months, that is for all services, is 22. And of that number, 15 of those are residential services. Of the total involuntary terminations not transitioned in the last year, all services, that's 23. And of that total involuntary terminations not yet transitioned in the last year, residential only, that is 18.
Thank you,
Thank you,
Elizabeth. I
Elizabeth.
can't believe I left that off the agenda. I apologize to all the
Oh, and I
committee
came all
members.
dressed up and everything.
Does anybody have any question in relation to the involuntary termination numbers from the report, please?
This is Melanie. Can I ask a question?
Go ahead, Melanie, and then we'll get you, Amy.
Okay, thank you. Just to help with, and thank you for that information, Ms. Markle. I appreciate that. With the, do you have a sense of the kind of medical diagnoses or reasons and or counties that the involuntary terminations come from? And my second question, if I could have a second part, is what will happen to these individuals when the involuntary termination occurs? You know, where do they go?
So I'll answer your second question first.
Okay.
Okay. Per regulation, an agency is required to continue to provide services to an individual until which time another provider has been found. The case management agency, when an involuntary termination notification is issued, goes to the task of sending referrals and trying to coordinate that. That's why of the involuntary terminations that have not yet transitioned, that means that those folks, even though they have been issued an involuntary termination, they're still being served by the agency that issued that.
Okay.
If that makes sense. So some of the reasons why we see involuntary terminations, one is an agency chooses not to continue to provide services in a particular area. So if they're choosing to involuntarily or voluntary close an agency in a particular area, then they would issue the involuntary terminations. In some instances, individuals that an agency has served over a period of time, we might start to see some of those medical concerns that many of us in our own situations might, from a caregiving role, begin to see difficulty in supporting them. So that might be another reason they may feel that they need more of a nursing home situation or something of that nature. And then I would say of those who have not transitioned to other agencies currently, of those being in residential situations, I suspect that would be more closely related to behavioral needs that have either changed over time or have come to a place where that particular agency feels that they do not have the capacity to support them going forward.
So it's a challenging
Amy?
situation.
Oh, I'm sorry. Were you
no,
done, Melanie?
I just want to say it's such a challenging situation. On a personal note, I experienced this a long time ago with my loved one, and it's awful. And so I hope we can. My prayer is that we find a solution to meet the needs of these individuals. Sorry.
Go ahead, Amy.
I just wanted to jump off of what Melanie's last comment was. You know, we've got, it seems 18 individuals specifically in residential services, which is, 24-hour care, whose provider, for a various number of reasons, has said we can no longer support this person, and has been doing so for, a period of time of the last 12 months. I think that becomes very dangerous for staff who are supporting that person when that individual, maybe the reason for the involuntary termination is behavior issues, becomes very dangerous for the roommates of the individual, and becomes also very dangerous for the individual themselves. And so as a collective group, we need to come up with a solution when a provider is waving a white flag to say, and saying, I can't do this anymore. I'm not equipped to do this. I don't have the resources to do this, to find, to expedite the process to get that individual into a much better environment for them. And that environment, maybe different things, but we've got to do better. The system has to function better to make sure the individual being supported is in the right situation for them and isn't being supported by a provider that's waving the white flag saying, I can't do this anymore.
Johnny, I see your hand up.
Yeah, thanks, Wayne. Just a question for Elizabeth. Elizabeth, do you know how many of the people who are getting residential services but had involuntary termination notices given are in psych hospitals and just kind of stuck there? They can't really go back, or they're not ready for discharge, but they, really don't need to be there. Maybe they are ready for discharge, can't find another provider. Do you have a count of how many people fall into that situation?
I do not have a count of that. And I'm happy to see if there's a way that we can get that information for you. I will say, just because I know, because I follow these very closely, that the 18 are not hospitalized. They're still being supported by the agency. They've returned to the agency. And I would say, just again, off the top of my head, would say that several, if not most of those folks are being supported through exceptional support services, meaning that they would probably have a ratio of a 1-to-1 staff situation, which may have improved their ability to continue to serve that person. And sometimes agencies are continuing to serve someone, but they don't necessarily drop them off of an involuntary termination. So that is one of the things that we have our quality administrators following up on as these reports are done, to kind of assess the situation. Sometimes agencies are like, well, we're serving them, but we'd really prefer not to be if someone else could or will. So, you have that variable in there as well.
Sure. Okay. Thank you.
Other questions? Ann?
Thank you. I'm sorry, I don't know how to do the little hand icon. I agree with Amy that we need to discuss what to do about this, and I don't know how to go about that. But it is a problem for the people being terminated and for the providers as well, which is kind of like a family council thing, getting together and talk about it, right? But I think both sides of the issue need to be included in the discussion. And how do we make this happen? This is a serious problem for everyone. Amy's correct. People are getting hurt.
Hey, Wayne,
Yes.
would it be okay? Our new director, Carmen, just got out of her meeting and has walked by my office. So would you all like for her to introduce herself and give a little bit of history?
Sure, she can come in and people can think about what we were just discussing and everything, and we'll come right back to it.
Okay. All right. I'm going to get up and I'm going to let her sit here so that the camera will pick her up.
Good morning, Mr. Harvey and the rest of the TAC. Thank you for letting me hop in here at the end. I'm sorry that I was late. I'm seeing names on the screen and I know I've worked with many of you all before when I was at Communicare. I was at Communicare a long time ago, worked with all of the waiver programs except for Model 2. I went on to build programs with managed care organizations working on social determinants of health. And most recently, I served as executive director for Recovery Works in Elizabethtown. So a little bit of substance use disorder in there as well. I'm really excited to be coming back in as the director for long-term services and supports. And I look forward to working with you all.
Awesome, Carmen. Welcome
Thank
to the
you.
committee, and we expect to see a lot of you from this point forward.
Yes, sir. Absolutely. I know that's what I've been tasked with, of course.
Absolutely. Does anybody have any questions for Carmen right off the bat? We can put her on the hot seat. No, I'm just kidding.
This is I'm in week 3, so be gentle.
You want to ease into things, right?
Wait,
No, I don't think it works like that, sir.
I'm a April Fool. You don't get to ask questions. That was an April Fool's joke.
No, but thank you
Yeah,
all.
that would be a drop mic moment if you just got up and said, "Hey, all this was an April Fool's joke."
Oh, well, we didn't think about that in advance, so next time.
Does anybody have any questions for Carmen?
This
Hey, we
Melanie
really
here.
appreciate you. Hey, Melanie does. Go ahead, Melanie.
And welcome. Thank you for coming and being a part of our meeting today. And I guess what I'd like to do is make sure you come back to be a part of this in the future. We've got great people that come from the cabinet, but it's always nice to have somebody in your capacity to kind of be able to hear issues and concerns and from both sides of the I'm a caregiver, a parent of someone that has been very blessed to benefit from some of the waiver options in our life, but it's been a journey, and so I think that there are really important pieces of information from hearing from both sides of the table. So please come back.
Absolutely. Yes, ma'am. Anyone else? I see you, Brett Schneider. We work together. I'm trying to see everyone here. There's a lot of people on this call.
Absolutely. Anybody else have anything for Carmen before we get back to the agenda items?
I'll just say congratulations, Carmen, and welcome.
Thank you, Brad.
Look forward to working with you.
Mm-hmm. Okay, thank you all.
Okay, going back to talking about involuntary terminations and so forth, that's been an issue that this committee has worked on for 2.5 years, basically. Probably closer to 3 years than 2.5.
Hey, Wayne.
Yes, Brad, go ahead.
Yeah, if it's okay, I'd like to go ahead and make a motion related to involuntary terminations.
Sure. I think that's what Ann was asking for a while ago. So.
Yeah. So I'd like to recommend that the IDD TAC recommend and request that CHFS modify the involuntary termination requirement within the SCL and Michelle P. waiver regulations to establish a time frame within which a certified provider is obligated to continue supporting an individual that they have indicated they can no longer safely support. This TAC recommends a similar time frame as the state of Virginia allows, which is 60 days within their involuntary termination process as discussed in earlier IDD TAC meetings. And just want to note that this recommendation is made in the interest of preserving the health, safety, and welfare of individuals receiving waiver services funded through Medicaid.
Okay.
Wayne, I'd second that motion.
Okay, that's what I was getting ready to ask for. Thank you, Doug. I appreciate that.
Oh, and
Discussion on the
yeah,
particular motion that Brad has made.
I have a question. Are you suggesting that, help me to understand what you're suggesting?
Well, we're
Hey, Melanie.
suggesting a time frame of 60 days within which, after a provider has provided their notice of termination, that a participant would need to go elsewhere.
And is there a recommendation within that there is an elsewhere defined?
Well,
I
I
guess
think
that's
that would
my
have to
only
be
concern.
worked out.
Melanie, this TAC received testimony from several other states over the past 3 years on how their process works, particularly individuals who testified from Virginia and I believe New Mexico talked about their processes. And they testified that both have 60-day timeframes for involuntary terminations. And because of the timeframe deadlines, providers and other service providers, they never experienced an issue referring someone out. And in fact, the woman, I believe it was woman from Virginia, testified before this TAC that they had never encountered a situation in over 5 years where someone met the 60-day deadline and did not have some place to go. They work closely with state partners and providers. And again, this is just a recommendation to the MAC that the Cabinet for Health and Family Services explore this and work this out. This isn't a recommendation that they implement that immediately, but I think this gets the ball rolling on, like we said, doing something to ensure that individuals aren't being supported in environments that are not safe for them.
Wayne, this is
Yes.
Erin. Two things. Miss Anderson with Cedar Lake, and I'm sorry, I can't see your first name, Miss Anderson, has her hand raised. And also, Brad, if you could send me that in writing. I was trying to type as fast as I could, but I don't think I gathered all of it.
Sure, no problem.
Thank you.
Let's go ahead and let Miss Anderson from Cedar Lake speak. She's probably had her hand up for a while.
I'm waiting patiently. As a provider who's supporting one of the 18 people on this list, we've been supporting this person for over a year after having served notice to her. She is at risk. She's at risk of being jailed. She's at risk of being hospitalized. She's at risk for being institutionalized. The people who are in charge of supporting her direct support professionals, are at risk of being harmed because our system is not capable of managing the care that we are charged with providing to her. And I think I'm happy to hear this motion being brought to the table and the recommendation to move it forward, because the work that needs to be done is not how do we make it easier for providers to say they can't support somebody. The work that needs to be done is what are we going to do to support the people whose needs are so significant they can't be managed under the current service models. That's the work that needs to be done. I don't think there's any provider. I think hi Julie Page. I don't think that anybody wants anybody to be homeless in this situation. But at some point you've reached the end of, and to use the language in the regulations, your ability to maintain health, safety, and welfare for those people.
Thank you. Other discussion.
Wayne, I
Ann,
have
go
a
ahead.
question.
Go ahead.
Yeah, so where are they going to go? No
Well,
other provider will accept them.
Well, in other states, when no other provider accepts them, they usually go back into an ICF for a temporary stay to get stabilized and then come back to community-based services.
Get stabilized.
Again, I just want to point out that this recommendation does not require any changes. It gets the ball rolling on the discussion within the Cabinet for Health and Family Services to develop a solution and a system of a solution, right? With feedback from others.
I don't feel that this is an appropriate solution.
Any other discussion?
I think you're going to be putting people in danger is what I think. So, wow.
Any
Wow.
other discussion in
I
relation
would
to the
say
motion
by
itself?
keeping people in these situations where a provider clearly feels they can't meet that individual's needs, puts them in danger.
But you know, there may be more involved than just the provider saying that. It may be that the provider's not willing to do what's necessary. There's a lot more involved. So, oh, wow. Until there's another appropriate residential setting for people, I don't think it's right to place them back in institution. That's not appropriate. And Amy, I realize it's just, what did you call it? You're just asking the MAC to consider it.
Where I think the recommendation, it asked the Cabinet for Health and Family Services to explore a system in which when a provider says that they can't support someone, to have hard and fast deadlines. The recommendation does not recommend reinstitutionalization. The recommendation does not come up with a solution of additional placements. It asked the Cabinet for Health and Family Services to develop a system that keeps individuals out of dangerous residential placements when their provider can no longer support them.
Johnny, go ahead.
Can we restate the motion, please? It was a little lengthy. I'm not sure I remember the language in it. What exactly is the motion?
You want me to read it off? I captured it, Brad.
Either way.
The motion itself is the IDD TAC recommends and requests that CHFS, the Cabinet for Health and Family Services, modify the involuntary termination requirement within the SCL and Michelle P. waiver regulations to establish a time frame within which a certified provider is obligated to continue supporting an individual that they have indicated they can no longer safely support. This TAC recommends a similar time frame as to the state of Virginia allows, 60 days, with their involuntary termination process as discussed in earlier IDD TAC meetings. The recommendation is made in the interest of preserving the health, safety, and welfare of the individuals receiving waiver services funded through Medicaid. Did you get it that time, John?
Okay. I did. Thank you. I just, wanted to hear it restated.
So I have another comment.
Well,
So
we
what's
got
it-
Julie. Julie had her hand up first, Ann. Let's go to her. Julie Page, go ahead.
Thank you. I was doing this because I couldn't figure out how to fix my little avatar name. So I have a question. If anybody knows the other states that you mentioned that have the 60-day deadline, do they have additional waivers besides what we have? Because I'm wondering if they have other programs that help certain populations. I feel like that's part of the issue here is we have participants who may, or they're borderline on the IDD diagnosis, and they have severe mental health issues, which is part of the issue and part of the challenge of getting them appropriate placement. So I just wonder if those other states have additional waivers that help that population.
Julie, I can answer that. So again, this was the previous TAC chair, Rick Chrisman, invited Virginia, and again, I believe it was New Mexico. And Virginia was very specifically chosen because their system of care very closely mirrors Kentucky's. So they have nearly an identical system, and this they have absolutely no problem getting people to accept high needs referrals, because providers in that state know that if I get myself into a difficult and dangerous situation where I realize I can't support this person, that their needs far exceed what I can provide as a provider, then we can send out a referral and someone else who may be better equipped to do this is likely to accept it. Again, I think Kentucky, we've gotten ourselves into a situation where people get nervous, right? I think you see that being at 7 counties, right? You all often have to deal as the referrer, right? Trying to find placements, things like that. And in other states, they have a system that gives providers absolutely no hesitation in accepting high risk referrals if they know that if they get into a situation where the needs of the individual far exceed what they can provide, they can seek additional referrals to help with that individual. Because again, as I think we all know that sometimes the narrative that gets sent around doesn't always tell the whole story, et cetera. There are issues in the system that far exceed this. And again, this is just encouraging the cabinet to develop timelines, et cetera. It does not outline the process.
And you had something else?
I did have a question. It seems like if the termination is involuntary, that means that the person doesn't want to go. And that if we force that person to leave, then that takes away their choice, and which is a violation of federal law and state law because it's
the term involuntary termination
centered.
is something that exists within our regulation. That is a regulatory defined term. The involuntary in there doesn't necessarily mean against the person's wishes, right? That's just the regulatory defined term that has to be used when we talk about these things. Frankly, I wish they'd rename it because I don't think it's a very I don't think that the name of the type of termination is necessarily very descriptive of what exactly is happening, but that's just the term within regulation, which is why it's used here.
So that's confusing, Amy.
Okay, any other discussion before we put the motion to vote?
Oh,
Wayne?
Yes, Johnny, go ahead.
Is there, one of my concerns is that, first, the risk of, I guess, reinstitutionalizing a person. But is there a way that the cabinet could have, more of a role in finding, services elsewhere? I mean, I understand the experiences of other states. However, I mean, I've been in this situation before too as a provider, and other providers in the state don't step up and agree to serve a person who's been. I mean, referrals go out and they go out and they go out, and if it was going to work that way here in Kentucky, then it would. But that just doesn't happen for a person whose needs can't be met safely. And I understand the predicament. I really do. I've lived it and been there many times. But I don't think that a provider a couple of counties over or in your region is going to say, yes, we'll do this when you can't. We have people waiting now, and it just kind of doesn't happen that way. So maybe there's a way to look at revamping exceptional supports so that finding other services is more likely for this particular person whose needs aren't being met safely, and the provider just can't do it anymore. And there are a lot of factors. Staff get burned out. There's high staff turnover, difficulty recruiting staff, and again, just a number of factors into why involuntary termination notice would be given in the first place. So and I know we do have folks who've, had this in place for a year or more, sometimes, going way beyond a year, in which no other provider has agreed that they could support this person either. So to me, that's the dilemma. Maybe other states have other alternatives, maybe better crisis supports or other, things, services and resources that can be brought to bear to help a particular situation. I don't know that we have that in Kentucky, or we wouldn't be having this discussion. So those are my points on this. It is a difficult predicament. It really is. And it's been, this and other groups have tried to tackle it for a number of years. So it's a thorny issue.
Well, I think one of the things that, and you alluded to, your past there, Johnny, and being a provider before yourself, used to the waiver regulation had a 30-day time frame in it in relation to, that's how long the provider was responsible. And when we transitioned into SCL2, the waiver regulation got rewritten, and all of a sudden this requirement came along that providers now had to continue serving this person indefinitely, basically, the way the regulation itself is written. Is that the safe answer here? And we've been on this subject for, like I said, before we went into the call for recommendations here, when we were discussing this after the report was given in relation to the numbers and so forth, we've been on this for 3 years. I think Brad's motion, all he's trying to do here is to get some movement on the cabinet side towards making some progress and doing something about this issue, as several committee members have stated in the past that they'd like to see something done on this issue. I think he's simply making a motion to try and do something about it. Go ahead, Ann.
Thank you, Wayne. Can we change the motion to say that, to instead of saying study ending involuntary or 60-day notice, or however it was worded, to asking them to study alternatives? I mean, do we have to go straight to eviction? Why can't we study alternatives first? Let's ask them that.
Brad's made a motion. I'm not inclined to alter the motion unless you're suggesting something specific.
I just did suggest something specific.
I see a message from Rick Chrisman, our former chair. He's asked if he could speak. Rick, if you're on here, yeah, go ahead and speak. Rick? Am I seeing things, Aaron? Did he send a message asking if he could speak?
No, he did, and I'm flipping through to see if I can find him.
Oh,
You're not seeing things, I promise.
are you allowing me to speak? I'm sorry.
Yes.
Okay.
A ghost from our past.
Thank
Go
you.
ahead, Rick.
Okay, well, I do like the motion for this reason, because I think one of the problems is that a person never has another opportunity to be served by another provider, because all these other providers are afraid of being, you might say, trapped. Okay. And it's been my experience that sometimes just a change of environment for some magical reason can turn a person around. And these individuals don't ever have that opportunity because no one's willing to take a risk, if you will. But if there is a time limitation, that risk is minimized. Does that make sense? And perhaps after a certain period of time that they've been through multiple providers, maybe then we can look at institutionalization. But let's see if other providers in our state have that ability. And sometimes they just will for some reason, because it's simply a change of environment. Does that make sense?
Absolutely, Rick. Any other discussion?
The
Yes,
problem
Amy.
with, thank you, Wayne. The problem with that, Rick, is other providers won't give them that opportunity.
But they're more likely to give them an opportunity if there is a time limitation after they determine they cannot serve that person. Then it makes it much easier for an alternate provider to say, yes, we'll try.
Well, possibly, or that might be wishful thinking. I don't think there's a guarantee that that would happen.
No, there is no guarantee. But at least before we look at institutionalization, which I guess is kind of what we're leading up to here, at least we've had the ability for every or all providers in the state to have an opportunity to serve that person without the risk.
It
And I think
sounds
that
like,
can work. I think that can work in many instances.
well, it needs to work in all instances.
Um,
I just don't
no-
know what's going to happen. What do you think's going to happen to these people? Where are they going to go? I mean, ICFs don't have to take them. I think this is not, I think there was a reason for this regulation to be implemented in the first place. And I understand that you want to undo it. But
Well,
don't-
I think we're trying to make it like other states are doing it. Okay. As Amy described with Virginia.
Yeah, Rick, I think we're the only state that has the requirement that you have to indefinitely serve someone.
You know,
that
I don't
correct?
know. I don't know if that's true or not. But if
Okay.
nothing else, let's do some more research. Let's find out what other states do. While I was on the board or the committee, we brought in some, you know, as Amy mentioned, 2 different states. Every state does it differently, and it's a shame states don't share information like this all the time. But or we could study it some more. Certainly, there's a whole lot more we can learn from other states. But at the end of the day, what I think the problem is that mandatory that you have to continue to serve that person, even though you have concluded you cannot. And that makes it so much more difficult for alternate providers to step in. If that makes sense.
Wayne, this
Melanie,
is
go ahead.
Melanie. And thank you for your comments, Rick. What is the way that the regulations are written in Kentucky, could an individual be served by a provider that's out of state?
I don't know.
Oh,
Yeah.
Generally speaking, no.
could because that could be something that they could investigate, looking at the surrounding there was testimony by a parent earlier that ended up having to go to Wichita or somewhere to get the services for their teenager. And so I know that people do end up traveling to other places because they can't get the residential support that they're needing within the state. But this is somebody that's not currently in any kind of system that's involved with the current waivers.
Yeah, Melanie, a person enrolled in a Kentucky Medicaid waiver cannot receive services outside of the state.
Okay.
And that's not just a Kentucky thing that's a CMS thing.
Oh, okay.
I hear somebody say that you all have been talking about this for 3 years. I think this is maybe my 4th TAC meeting that I've sat in, and we've talked about the numbers in every meeting without really any recommendations to do anything about it. So for one, as somebody who observes these meetings, I'm happy to hear that there's a recommendation, and my hope is not to be relieved of responsibility to a person as a provider. My hope is that it begins to have some discussion around how can we wrap supports around people who are difficult to serve so that they can be successfully served. Not to have responsibility relieved. Once you agree to support somebody, you've invested in that person and in that family, and it works best if you can figure it out. But when it's too dangerous for the person that you're supporting and for the community that they live in, it's not an okay situation. So just to continue to do nothing about that is not okay.
And I just wanted to add to that discussion that the Kentucky legislature did an entire task force about this very issue in the interim of, I believe, 2020. And they released extensive findings and recommendations about how to solve these problems. And they really just never went anywhere. I'm happy to distribute those, but CAP members, you would have gotten those recommendations back in 2020, but I can resend those out. But among those recommendations were to, number one, put hard and fast deadlines for the what is termed regulatorily the involuntary termination. Number two, overhaul exceptional supports. Number three, explore a system of residential crisis services within the state and implement those. And there were a list of about 15 recommendations that, you know, obviously do take funding to implement, but never went anywhere. So again, this problem's been discussed extensively, and that legislative committee received lots of testimony from lots of different stakeholders during that time. And those meetings, those documents are actually still available on the LRC website.
Any further discussion before we put this to vote?
Wayne, I just wanted to, say thank you to Amy for bringing that back up and pointing it out. I think those were, there were some good recommendations that came out of that work, and, you know, unfortunately weren't really implemented. COVID hit, and then a variety of things, but and it does take some funding to have some alternative, you know, to residential. It's hard to just kick people out. And then also, you know, a crisis response system, and then to revamp exceptional support. Some people just need more support than other people for, you know, a lifetime. And you know, for some people, it's probably not going to be time limited. But I think those things would have, you know, would go a long way toward, you know, helping alleviate some of these situations. But they, as Amy pointed out, they really weren't implemented. They were just, you know, they were findings and recommendations, but not implemented. And that's unfortunate.
All right, any other discussion before we put it to vote? We're close to running out of time here. These Zoom calls are scheduled for a certain time block. Our time runs out at 12 noon. So
Wayne, can we put that, what Johnny and Amy talked about from the 2020 time period, can that be included in the, what you're suggesting that we have some kind of vote on?
well, the information itself can be sent out to each committee member. Are you asking that that be attached to the motion?
Well, I think that, because that there's been efforts done, what do they call it, admiring the problem, and there were recommendations, but there was never any implementation from what I'm gathering from the task force or whatever. And I'm just hoping that that could be incorporated into what we're
Here's the thing, Melanie. The recommendation itself, if it passes, we don't know that it'll pass even, but if it passes, it goes forward to the MAC. And then the MAC requests this of Medicaid. That doesn't obligate Medicaid to do these things. It doesn't obligate Medicaid to specifically do as the recommendation requires. But what it does do, it requires Medicaid to give us a response to that. You know, if they look at it and say, well, we can't do it because of this reason or whatever, they give us, you know, they're obligated to give us a response on that. And we may be back to the drawing board again and looking at information for who knows how long, how much longer or whatever, to determine what somebody else may come up with as a particular motion to address the issue. You know, that's how that process works. This particular TAC cannot force Medicaid to do anything, basically. Yeah. We can make recommendations to MAC all day long, and MAC can forward those recommendations to Medicaid and force a response to that. But, you know, other than that, you know, we don't have the ability to force them to do anything, is what I'm saying, basically. We're hopeful that this particular motion will get people to start thinking about this issue as a serious issue and do something about it. And maybe they'll go back to the things that Amy mentioned and draw those things out and start implementing some of those things. I don't know. I don't know what their reaction will be. But I do know that, you know, a motion was brought forward by a member of this committee, and you know, we need to see this motion through to the end and see whether or not it's a recommendation that I'll be allowed to present at the next MAC meeting.
Well, let's vote, because I want to make a recommendation also, and we're going to run out of time.
Okay. All in favor of the motion that Brad set forward? Do I need to read it again?
No.
Okay. All
Do we
in
need
favor
to
of
do
the motion?
a roll call vote?
Well, we can. Aaron, do you want to conduct a roll call vote, please?
I sure can. Wayne,
I vote yes.
Johnny,
I have to pass.
Melanie,
I have to pass as well.
Anne.
Is pass the same as no?
Yes, ma'am.
Pass.
Doug,
I vote yes.
I believe that's all I have on. Did I miss anybody?
You missed Brad, the one that made the motion.
Oh, goodness. There you are, Brad. I'm sorry.
Yes.
Okay, so that puts us at 3-3.
Did Frankie ever log on?
No, sir.
Okay.
Nor did Sherry.
Okay.
May I ask you just a question about the vote? A pass vote, in my mind, is not the same as a no vote or a yes vote. It's just a
Means you're
pass.
abstaining.
That's
Basically
true.
means you're
A pass
abstaining.
is not a no vote.
Okay, should we vote again then?
No, I mean, I don't see a need to vote again personally, but I'm just say when you said that or when Ann asked the question and you said that it's the same as a no vote, I was just hoping to clarify that it's not the same as a no vote. It's just a pass on this particular motion. But anyway, thank you.
Okay, well, the vote's 3-3, so the motion doesn't pass.
So
Well, if we had two people pass, that means they didn't vote. I've never had a TAC not agree on recommendations. So
okay, well, then does that mean it's 3-1 then?
that's why I asked if you guys wanted to re-vote.
Okay.
Because sometimes in some other TACs, when people say pass, they mean no. So it.
Aaron, didn't it have to be a quorum of vote though? So if you don't have
They have a quorum, Alicia.
But the quorum didn't, there's not enough votes to count as a quorum because you had 3 people pass, correct?
That's right.
So I don't know. Aaron,
That's why I
there might
asked
be
if they
one-
wanted to re-vote.
There
Yeah.
has to be an odd number.
It's my understanding there is a quorum to conduct business, so the quorum is
Yes,
present.
we have 8 members. We have 6 people current. So why don't we just vote again? So Johnny, and you wanted to pass, correct? So that's no vote. Correct?
I'm sorry, if I can ask for
It's
clarification, I don't understand pass. In Robert's Rules of Order, there's a yes, a no, and an abstention.
Yeah, abstain, yeah. So we probably do need to revote. This time, if you want to pass, Johnny, just abstain, just say the word abstain. I think that will take care of the technicalities of the vote itself. If that's okay with everybody, I'll go ahead and lead us off. I'm voting yes.
I
Doug,
vote yes.
Brad,
I vote yes.
Johnny,
Abstain.
Ann,
No.
Melanie.
Abstain.
So we have 3 yes, 1 no, 2 abstain.
So does the motion pass, or?
You have 3 yeses. So yes, sir,
Okay.
that should pass.
Thank you. All right. And you said you had a motion that you
Yes.
wanted to make?
Yes, 1 minute. I move to recommend the need for family councils and community homes and intermediate care facilities.
Can you read that a little bit slower?
Yes, I move to recommend the need for family councils in community homes and intermediate care facilities.
Are you saying that there is a need for the family councils to be present, or?
I'm
Your
recommending that
motion, the way it reads, it's a little ambiguous.
okay,
I don't really
move-
know exactly what you're asking us to take forward as a
I'm
motion.
trying to tell you. I move to ask the MAC or to recommend to the MAC the need for family councils and community homes and intermediate care facilities.
Okay. Anybody second that motion?
This is Melanie. I second that motion.
Okay, Melanie seconds the motion. All right, any discussion on the motion itself?
I just wanted to point out that families can already form family councils if they so choose. There's nothing in Kentucky law that prohibits that.
Any other discussion? Okay, let's do a roll call vote again, Aaron.
Okay, I lost my pen. Wayne,
I'm going to abstain.
Doug,
I'm going to abstain.
Ann,
Yes.
Melanie.
Yes.
Let me toggle over. Johnny,
Abstain.
Brad.
Abstain.
Okay, we have 4 passes and 2 yeses. That does not carry.
All right. Any other discussion before we talk about MAC meeting representation real quick, because we are running over. Okay. We did have two recommendations that Doug Hoyt, who was representing myself at the last MAC meeting, he did present those for me. They were the 2 recommendations that came out of the particular meeting last time. Those were approved and forwarded to Medicaid. The next meeting is May the 22nd. And it will be from 9:30 to 12:30 Eastern time, and I plan to be in attendance. The next TAC meeting is scheduled for June the 3rd at 10 a.m. via Zoom. Do we have any other questions or anything before we close? We are running over. Okay. I want to thank all the cabinet representatives that presented information today and was kind enough to speak to us and provide information to us from the cabinet itself. And I want to thank Marla, who presented on family councils today. That was very informational to all committee members that really didn't know anything about family council. So we really appreciate that. And we will see you guys in June. Thank you very much. Meeting adjourned.